ventilation. This means for those people who are sick enough for one reason or another to need mechanical ventilation. This means if we don't start mechanical ventilation, we think you're going to die. And a number of pulmonary fibrosis experts say if this is the natural progression of the disease, going on mechanical ventilation is not going to get you where you want to be. It means you're going to spend your last days in a hospital, in an ICU. But other people disagreed and said, yes, but suppose it's something that's fixable, like a cold, pneumonia, something that could be treated with antibiotics. And everybody agrees there are a lot of times we don't know for sure about what's going to happen to somebody with pulmonary fibrosis who needs mechanical ventilation. Maybe we can fix something enough so we can get them off the ventilator. So we don't always know, and it's a tough call. So, if I could summarize all this, there's no proven benefit to any medical therapy yet, at least not according to experts in the United States and many people around the world. And therefore, there's no official recommendation for what to do. Treatment with corticosteroids alone should not be considered a standard therapy. Everybody agrees with that. Prednisone by itself has a lot of side effects. It's dose dependent, so I can't say absolutely that a small dose might not help somebody in some way, but in terms of trying to reverse pulmonary fibrosis or stop it, we don't have any evidence that that works, at least not idiopathic pulmonary fibrosis. Several new agents have not proven to be beneficial, bosentan, and pirfenidone's sort of on the border because there's some people that think it works. The experts in Europe thought it did, approved it, and therefore Canada has also approved it. But in the United States, we're still not to that point. Lung transplantation for those sick enough to need one and well enough to get one, that's certainly something that can be beneficial, but certainly not without risk. Good practice. What should we be doing for patients with pulmonary fibrosis? We should take care of their oxygen levels are dipping too low. If they're staying down, oxygen should be given for activity, sleep, or maybe full time. Physical activity rehabilitation programs, I've already said, are underutilized and should be standard part of treatment. Try and prevent infections. So vaccination against influenza, the most common form of pneumonia, the pneumococcal pneumonia, and against pertussis. That's the whooping cough. And there's a resurgence of that in kids. And if you have grandchildren or any kids, if you're around any kids, you don't want to get this either. So if you haven't had your pertussis shot in a long time, that would be a good thing. Treat infections quickly, and lung transplant consideration, at least beginning to think about it right from the beginning. Education, support, regular monitoring, with vigorous attention to trying to control symptoms, especially any acute change in symptoms, treating complications like GERD, pulmonary hypertension treatment in association with idiopathic pulmonary fibrosis, we're not sure about. And they ask about, this is really about what I say to doctors, but in your case it applies as well, ask about, plan for, supply as needed, handicap parking stickers, home necessities like shower chairs, bedside commodes, hospital beds, wheelchair, things to make life easier as the disease progresses, control cough or suppress it as best you can if it's troublesome, and then do what you can for shortness of breath in suppressing that symptom, and have an emergency plan available. What are you going to do if you have to go to the hospital? If things get bad enough that you're thinking about it, you want to have a kit ready to go. It's got your medical records, your medical information, your medications, so that when you get to the hospital, you don't have to try and remember what it is that you or your spouse has that we're trying to tell the doctors about. If you got a list, that's good enough. If you carry the medications, that'll do. So you ought to be prepared for some emergency that might take you there. And at some point, you need to think about whether you need assistance in the home or maybe hospice as a plan for how your life might end. That's a pretty heavy conversation. You asked about what do I recommend for treatment. There's no approved treatment in the United States. I recommend people help out the rest of the IPF population, get involved in a trial. That is, get involved in one of the ongoing trials to treat pulmonary fibrosis. You won't know whether you're getting the real drug or the placebo. For right now, we don't know of anything that's better than placebo. Questions? Yes.
You said about the prednisone. I think most of us that have IPF that are here today are taking prednisone.
Yes.
Probably some of us are taking it with something else.
Yes.
So that takes care of what you mentioned earlier, that having it in conjunction with something else is probably okay. You didn't mention cell sept. And a lot of people that have IPF, well, maybe not a lot of people, are taking cell sept prior to lung transplant. Cell sept is an anti-rejection drug.
Mycophenolate is
if you're taking that in conjunction with prednisone, have you ever heard of that comment?
Oh, yes. There's no proof that that's better than nothing. One of the disadvantages of being on something that's not been proven is you are now taking drugs that we know have side effects. So the side effects might be worse than the disease itself, because you've got the disease and now some side effects to go with it. So long-term prednisone, the disadvantage of prednisone can be given at any dose. There's no standard dose. The longer you take it, the higher the dose, the more likely you are to have the complications. And the complications are things like weight gain, high blood pressure, diabetes, cataracts, osteoporosis.
My sister, her took so much prednisone, I take it all the time, but my sister in Rhode Island took so strong doses of prednisone that her interior organs all developed pinholes, and it got so bad they couldn't stop and she died. But I still take it in small doses because, to me, it's better than the effects from my COPD and my arthritis.
How long did she take it?
She took it for years. She took as much as 60 to 80 milligrams at a time for long periods.
Way back.
In one of the last few statements,
I'm going to tell you, I'm hearing it's not good. So.
mine's lousy too, so here we go. One of the last things that you said was that there are no approved treatments in the United States. So to me that leaves the unanswered question, are there approved treatments in other countries that just have not been approved here?
Yeah.
And are they in like North America or are they just all Europe and Asia?
You can get pirfenidone as Briette in Europe, and it's approved there, and so it's on the market. Doctors can order it, people can take it. In Canada, you can get it too. It's on the market, you can take it. In Japan, it's approved by their agency, and people are taking that medication for their idiopathic pulmonary fibrosis. If you happen to be on vacation in India, you can buy it over the counter.
Is there concern with counterfeit drugs or anything with that particular drug?
I'm sorry, I didn't.
Is there a concern with like counterfeit or drywall in the pills with this particular drug?
Is there a concern about counterfeit drugs? I think there is in some places. Not in Europe, not in Canada. But there's not as close scrutiny in other parts of the world. I'm sure Japan is probably fine. But there are pharmaceutical manufacturing places in other spots of the world that are not carefully supervised, not carefully regulated, and the quality of their products is sometimes suspect.
Do you have an opinion on Fernando?
Do I have an opinion on pirfenidone? Yes, I do. I don't know. We've been, over the years, we've taken part in some of the pirfenidone trials. And I'm sure that I've seen a patient who was helped a lot by pirfenidone. He had well-documented declines in his pulmonary function, and then totally different rate of progression. His lungs still kept getting smaller, but that happens with age. And so we've seen a couple of patients that I think it really helped.
Is anything else going on that did he start exercising or?
Right. Is there anything else that's going on? The exercise is a good thing, but that doesn't change your breathing capacity. So measuring things that aren't really affected by the medication, like exercise. But I think it has, I've seen some patients where I'm sure it helps. But that's, how do we know which ones those are? And I think the FDA's point on this medication is we're not sure it really helps. We don't have strong enough evidence. And there are side effects with the drug. It's not easy. You have to work the patient up slowly to a full dose because most people have side effects. Some of them are things that you wouldn't think about, like being sensitive in the sun. That is, you have to get skin burn. For guys who like to play golf, that's not a great thing. But if they wear long sleeves, wear good sunscreen, put a hat on their head, they can prevent some of that problem. There's also some gastrointestinal problems that are unpleasant and usually dose-related. So if you get a patient up to the dose, they're having trouble, you can often drop the dose back. They get better, then you can try a little less aggressive dose. So you can often get people up to the full dose. It takes a lot of time and discussion about doing this with patients.